Okay, so the first speaker of the day is going to be Harvey Pass, and Harvey is a well-known and respected thoracic surgeon. He's really dedicated his career to pioneering surgery and as well understanding the biology of mesothelioma from his days at NCI, at Carmanos, and then now as chief of surgery at NYU. So just about anyone who has done research in this disease has collaborated with Harvey. And it's really for that reason that he's gotten such distinguished awards like the Wagner Award from IMIG and the Pioneer Award from the Meso Foundation. So I really appreciate you coming today, Harvey, and eager to hear your talk.
Well, it's good to be in New York until 12 o'clock when I have to fly out. But what I can tell you is that it's good to be in New York to talk about meso to you. And I appreciate that Lee asked me to do this because, as you know, New York is a very well-respected city with regard to the management of this disease. For me, though, today's speech is not going to be a typical Harvey Pass speech. The title is for the broad stroke of a paintbrush. And that's because this is not going to be Harvey Pass talking about data. This is not going to be Harvey Pass talking about survival curves. This is not going to be Harvey Pass talking about prognostic factors or early detection or the newest thing in the lab. This is Harvey Pass sort of laying out what the considerations are for surgery at this point in this disease. And I think it's appropriate that we sort of get down to the basics of surgery so that when you go look at places, or if you want to know about places or know about the surgery, you at least have a knowledge of what the idea of surgery is for mesothelioma now, and also who does it and what's being done and why it's being done. So in doing a speech like this, I think there's some basic questions. What's the use of surgery in pleural mesothelioma? What are the present limitations in deciding whether a patient should even have surgery for pleural mesothelioma? Why is there so much controversy about surgery from pleural mesothelioma? What are the types of operations for pleural mesothelioma and who are they suited for? And what, if anything, should be combined with surgery for pleural mesothelioma? First of all, let's not forget that surgery for mesothelioma is the definitive way to diagnose the disease. In the United States, we rely upon tissue. And the predominant type of pleural mesothelioma can only be accurately and consistently assessed with an adequate-sized tissue biopsy of the pleural abnormality, either by a mini pleural biopsy that's open or by VATS, video-assisted. And I show you an example here. Here are cells. These are mesothelioma cells. This is cytology. Many times you will have a reading that it looks reactive, it looks bad, but we can't tell. And some people actually base treatment on something like this. This is a pleural biopsy. This is epithelial mesothelioma. This is sarcomatoid mesothelioma with also an epithelial component. And this is another epithelial that looks tubuloglandular. Where are you going to get the most information from? I mean, you're going to get the most information from a biopsy like this that can be done safely. The patient can go home the same day or the next day if you don't get into the chest. You must have the right surgery. Therefore, don't forget about it's not just for treatment. It make the diagnosis, the correct diagnosis. So obviously, surgery is also used to help take care of fluid, because patients with mesothelioma are not going to just come in with solid disease. They're going to mainly come in with fluid disease to begin with. And certainly with a video-assisted thoracoscopic pleurodesis or look in there and put in talc, you're going to be able to palliate this very, very well. You have fluid, you put in the talc, the lung expands and it sticks, and it works very, very well. That's not what I do, though. Obviously, my choice these days is the Pleurex, or now a new catheter called the Bard Aspira catheter that works the same way, that allows the patient's independence. Meaning, if you can do a VATS pleurodesis, and it works, but it's a pretty invasive procedure. The patient's in the hospital. It can be associated with pain. I like the Pleurex because you can get the diagnosis easily from the cells. You can look to see how you're doing when you're treating the patient, and the patient is self-sufficient at home, taking care of himself instead of running back to the hospital. And an example of this is seen here, where a patient recently presented with an effusion like this, and then had a Pleurex put in, and you can't see it, but there's a little line right here that took care of this, and the lung expanded completely, which is also very important for the surgeon as a first choice to figure out what kind of operation. This lung expanded all the way. That means that maybe the bulk of disease is not that much, and it's not influenced by having a whole bunch of talc in there, and you can get an idea as a surgeon, maybe this is one that will fit into a lung-sparing type of operation. In this particular patient, maybe in 6 months we'll have the Pleurex catheter removed, which we can do also. But apart from diagnosis and effusion control, what about actually trying to cure pleural mesothelioma by involving surgery? So let's not kid each other, because you've heard this either through the books or on the web or from your doctors. It's very difficult to cure mesothelioma with surgery alone, because the biology of the disease makes it difficult for mesothelioma physicians to really accurately tell how aggressive the disease is. And this prevents the physicians from guaranteeing the patients that they're going to actually have a cure and not recur after surgery. So we're already getting into the idea of there are different types of mesos based on their biology, and we have no clue which one is the more aggressive one at the beginning of the scenario. The staging system for pleural mesothelioma is not good, and that's why we're spending money to make it better now through IMIG funding as well as through MARF funding and ISLC funding to have a better staging system. The disease usually presents at an advanced stage, close to my heart, because I'm looking for markers that will help find it earlier. Let's find the disease earlier, and it's difficult to cure now because we find the disease too late. The surgery is demanding, believe it or not, both for the patients and the surgeons, and only patients who have a good performance status can really go through some of this type of surgery. The disease usually presents as a combination of solid disease and fluid with malignant cells in it. How can you possibly say to a patient, I'm going to cure you with surgery, when the cells are floating around and you cannot remove every cell? You have the chance to treat aggressively, but you cannot tell a patient, I'm going to cure you with surgery alone. And then by its very nature, mesothelioma is a diffuse, not a localized disease. This is not like lung cancer where you take out one portion of the lung with the lesion and that's the end of it. It's diffuse, it involves surfaces. So on that topic, how can we possibly choose patients better for surgery? Who are the people that we can look at certain things and say they may be a surgical candidate? Well, we have a lot of different factors now that we think give us a hint. And we're looking into these now with the ISLC new staging system. Age obviously plays an important part. Females do better than males. We don't know why. Functional status and white blood cell count and platelet count, as well as the presence of chest pain, will give us some clues as to whether that patient is a good candidate or not. And there are pathologic factors. The type of mesothelioma. The conventional wisdom is that the epithelial is the best type if you have mesothelioma, and biphasics and sarcomatoids are not as good. I can tell you, though, that there are biphasics that do very well, and we just don't know why. So why do you have, we need other factors to say it's not just what it looks like, but it may be related to other things about this tumor and not just what it looks like under the microscope. Obviously, we have to choose patients based on whether they're going to be able to go through the operation and tolerate the operations. That's physiologic status. And then finally, the fun part, at least for the surgeon scientist or the scientist in the lab, and that's trying to figure out what the hell's going on with this disease on an individual basis. And that's looking at various things like genes and proteins and microRNAs and all sorts of stuff to try and, with a minimal biopsy, say, this is the way you should be treated. So the staging system is not very good. What do I mean by that? Well, tumor extent in mesothelioma is very, very important. And we know now that the greater the volume of the disease, the more difficult it is to cure patients. Nodal status is very important, whether it has spread to lymph glands. And tumor in the lymph nodes makes it very difficult to cure this disease. And you must rule out metastatic disease before you think about putting a patient through an operation like this. So that's why you have to get a PET CT. You have to look for occult disease. You don't want to have the patient come back 3 months later with something in the belly if you did a pleurectomy and you missed something before you operated. So what do I mean by the staging system? Well, here's a normal pleura. And if you have a mesothelioma, it'll start on the layer on the inside of the chest wall, and if it's just confined to that layer, that's a 1A mesothelioma. These are the ones, first of all, that we'd like to never see because we'd never have mesothelioma, but these are the ones that we want to find. And we want to find these in high-risk individuals. And we want to find people who have exposure to asbestos, and we know they had exposure, and we want to find these. And we want to find these early, because I think we can cure these. As time goes on, though, you can have involvement of the lung. And then when that happens, it's called a stage 1B, still curable with multimodality therapy. Very difficult to cure, but still you can see cures with that. But it's more extensive disease. As the disease progresses, it can get in between the lung lobes. That's not a contraindication to operate. You can dig those out, like you've heard with our studies on lung-sparing surgery. You can still do a good operation on patients like that. And in fact, if it involves the diaphragm and even invades the diaphragm, you can still do a good operation and even spare the lung, and the patient will be very, very functional. It's when it becomes more advanced like this, when the lung starts to shrink, when the patient starts to have chest wall pain because the disease is coming through that last layer, and then the patient is having discomfort, not just pressure, but discomfort, that we are starting to make it even more difficult to cure. And then obviously, if the disease goes through the diaphragm or ends up in other places like the liver, then we have to rely on systemic therapy for these patients. But figuring out before you operate exactly what you have on the basis of the scans we have now is very, very difficult, at least for me, who's been doing it since 1989. And the problem is that these are big operations that are done in elderly individuals. Now, we're seeing a trend toward earlier mesothelioma in younger individuals, but the average age is between 65 and 70 for patients like this in the younger series. And the problem also is that, there's a lot of surgeons that do mesothelioma, and we need to be able to talk in the same language. And up until recently, we haven't been talking in the same language because there's been no uniform definition of the type of operations we've been doing. When we talk about a pleurectomy, one man's pleurectomy is something to somebody else. So fortunately, that's actually been looked into, and I'll show you that in a minute. And then there's a bias among mesothelioma physicians that no operation is useful in mesothelioma, or certain operations are not useful in mesothelioma. And therein lies the beginning of the controversy and the difficulty for both physicians and patients to be able to figure out how to navigate these waters. So the first caveat that I put out there is that surgeons who do these operations are only now beginning to understand that one size does not fit all, and you have to tailor your operation depending upon how the patient presents to you. Fortunately, we do talk the same language a little better now. David Rice from MD Anderson published this paper in which there is a definition of what the different operations mean, and the importance of doing that was because people said pleurectomy decortications are no good, they're just debulkings, they mean nothing, and patients should have that only in advanced stages. That's wrong, and was wrong from the time when Valerie and I and other people started doing pleurectomy decortications back in the 80s, but we were getting down the disease we couldn't see. So if that's not a pleurectomy decortication, that's a debulking. That's a maximal cytoreduction. So here are the types of operations. The pleurectomy decortication. Who is going to be a patient for that? Usually less bulky disease. It's a great operation for stage 1 mesothelioma. The patient remains very functional because the lung is spared. The risk, as well as the morbidity, is lower than the other operation, extrapleural pneumonectomy. And the patient has to be aware, though, that the recurrence pattern is that it will come back in the chest. That's where you have to surveillance very carefully. The other operation, extrapleural pneumonectomy. Obviously, a more extensive and invasive disease will be that which is you can't do a pleurectomy decortication on. And if you do try to do that and you leave a non-functional lung, what you're doing to the patient is keeping them in the hospital longer with big complications, and therefore you have to decide, is this going to be a functional lung, and what do I have to do? The functional status for an extrapleural pneumonectomy needs to be even better than that for a pleurectomy decortication. It has a higher mortality, but still very reasonable now because of the centers that do this on an everyday basis. And the morbidity is higher. The recurrence, though, is a little different. The recurrence can be both in the chest, but mainly outside the chest, in the belly, the opposite chest. So the broad stroke is that a pleurectomy, you sort of peel the orange, as Joe Friedberg has alluded to, and you free up the lung, as you can see here. And if necessary, you can even take the diaphragm, and you're left with a patient who has a functional lung, is able to get more therapy, and therefore is able to get the effort effect with what we need to do with patients with mesothelioma. And what you're left with, this picture that you've seen thousands of times, this is from one of mine from 2 weeks ago, the lung looks pretty normal. And there was disease all over the diaphragm, and the diaphragm has been spared, and we took the stuff off the diaphragm, and you're left with a sheet. Now, this is not a stage 3 mesothelioma. This is an early-ish mesothelioma, but this is the patient that should be spared the lung, but should be given an operation that's going to get down to levels that you can't see. Extrapleural pneumonectomy, bigger deal. Have to open into the pericardium. Have to get all these structures mobilized so that you can release the lung. You have to expose the heart. You have to then repair the pericardium. You have to repair the diaphragm. Big operation, and you're left with an empty chest with patches to prevent the heart from coming this way, and a big specimen that you've all seen before. This is nothing new to you. The issue is making the decision to do the right operation for the right patient without being biased. And I will take pride in doing a paper with Raja that started the controversy. And back about 5 years ago, we published this paper, which was the combination of my series as well as Sloan Kettering's, and we published that pleurectomy decortication may be just as good as extrapleural pneumonectomy in certain cases. And people didn't like that. But the take-home message was that what you should like is the concept that it's a maximal site of reduction. Just like David says, David Sugarbaker, who's correct, you need to get down to levels you can't see. You have to remove as much disease as you can, and then you have to give other therapies. And how you do that depends upon what you're presented with and what the patient is presenting you with functionally and anatomically. But if you go into the situation with the idea that you can only do this operation, that's 1970s and 1980s thinking. And that should not be the way we're thinking in the 2000s. And then there are those who say there is no role for a certain type of operation. And this was a study that was done by our colleagues in the United Kingdom, in which they actually randomized patients to either get the big operation, extrapleural pneumonectomy, or not, after patients had gotten preoperative therapy. And their conclusions from this paper was that extrapleural pneumonectomy adds nothing. In fact, the survivals were a little bit inferior to not having an extrapleural pneumonectomy. And extrapleural pneumonectomy is dangerous because their mortality rate was upwards of 14%. And extrapleural pneumonectomy has a lot of complications. Well, duh, we've known that for a while. And this is a randomized trial, so you can't argue with it. Now, this did not make a lot of sense to some surgeons who've done this operation. And there was a reply. So you can see that it gets very testy, even in the literature, with regard to this controversy in surgery for mesothelioma. And a number of people here said, you are out of your mind. This trial only involved 50 patients, about 25 in each group, starting with upwards of 300. The patients here, some patients actually crossed over from one group to the other. So how do you interpret that? The mortality rate was unbelievably high. The mortality rate in the United States for this operation, at 3 institutions at least, is between 4 and 5%. So this has not gotten a lot of credibility. And my point is that there's still controversy about this, and there's even regional and geographic controversy within the United States as around the world. Obviously, up north, there's been a commitment to the use of extrapleural pneumonectomy, although this is changing a little bit. I can see this. The Swiss, though, still believe that extrapleural pneumonectomy with multimodality is the way to go. The Australians also seem to be pointing toward this way, while in the United States, UPenn, UCLA, United Kingdom, only pleurectomy decortication. That's the way to go. Everybody can have a pleurectomy decortication, extrapleural pneumonectomy. You know, we can do everything through a pleurectomy decortication. I'm not so sure, because then there are these people who are the heretics. And, you know, for me, I just may not be as good as some of these people here, but for me, if I have a patient that's young and I can't do a pleurectomy decortication, but I think that patient has a mesothelioma, and I think that they're going to be able to get, and I think I can do a maximal site of reduction, I will do an extrapleural pneumonectomy. And my practice since the 80s has been 2/3 extrapleural, 1/3 pleurectomy decort. So I think that, at least in New York, there is this idea of keeping an open mind about what type of operation. Now, so if I had to summarize thinking about this as far as where the stages are, so here's the early stage again, and here is a little bit more advanced when it's on the lung, as I said before, and that's stage 1. And then you have stage 2, a little bit more advanced, and then you have stage 3. So this is the way I look at it. I think that these are wonderful candidates for pleurectomy decortication, and this is where the gray area is, when it's more extensive. And I apologize to people who've been through this. I apologize to the families that have been through this. For me, sometimes I have to make that decision in the operating room. And I tell the patient I may have to make that decision in the operating room. So there are able to take an extrapleural pneumonectomy if they have to. But I just cannot guarantee, and I don't want patients to have unrealistic hopes, so they need to know when I'm concerned about the type of operation that I can do. These pretty much you can call real easily. These become more difficult. And then these with the advanced disease without lymph nodes, most of the time extrapleural, at least in my hands. So finally, what is not controversial? You must combine surgery. Am I finished? Am I done? No. God, I thought that was the hammer. You must combine surgery with other modalities. And the chemotherapy can either be given preoperatively or postoperatively. We tend to treat preoperatively now from the paper that the landmark paper that Lee published. And there's documented safety with that, and as well as improved survival. Not going to show you the curves. Take it from me, the curves move upward when you give chemotherapy. Radiation therapy postoperatively, no doubt, has an effect on local control, a good effect on local control. We're even thinking about doing this preoperatively now for pleurectomy decortication. And that in a protocol setting is a very good thing to explore. And then intraoperative therapies, which you're all familiar with, which include heated chemoperfusion as well as photodynamic therapy, where we're trying to figure out what are they adding besides a good operation. And I think they should be done, and they need to be done, and they need to be answered, and they need to be answered with more randomized trials. So finally, if you have surgery for pleural mesothelioma, you're going to have to be followed very, very closely, usually with CT scans, maybe with PET scans. At this time, there aren't any good blood tests to really monitor the disease besides SMRP, which is the marker that's out there. But back in June, I said stay tuned. And I still say stay tuned. And in fact, stay tuned in 2 weeks. Then you must use all the resources at your disposal to hear about mesothelioma centers and novel experimental approaches. And obviously, we wouldn't be here if I didn't say that the Meso Foundation is the source for this. Thank you. So Leah said we can do some questions now, I guess. Questions, please?
Okay, when you do the mesothelioma versus diaphragm, you go in and you do your surgery, and at that point you're messing with the diaphragm, what type of damage are you doing to the phrenic nerve, or are you damaging the phrenic nerve? Because that's also putting the patient at risk of having to have a phrenic nerve pacer or having to go on a permanent ventilator. And I'll let you know now, I am a respiratory therapist, so that's why I'm asking.
So, first of all, if you have to take the diaphragm for mesothelioma, number one, it is non-functional. Number two, most of the time. Number two, if you do enough of these mesotheliomas, you'll see that the mesothelioma on the pleura actually comes right on top of where the phrenic nerve is. So, number two, the majority of times, you've already sacrificed the phrenic nerve. Number three, you're putting a Gore-Tex patch in, so that's not going to move very well. So, that's why preoperative assessment of what the pulmonary function is important in these patients, because you're either going to do a good operation or you're not. So you're going to do a good operation to spare the lung potentially, and if you spare the lung, but you're leaving mounds of disease on the diaphragm because you think that you want that patient to have a diaphragm, that is the incorrect approach. So surgeons need to be able to have the leeway to decide that I need to get the disease down to the least amount. The diaphragm is replaceable if you have one on the other side, and usually the functional deficit in a patient that has moderate to moderately bulky mesothelioma is nothing with regard to the diaphragm. That's really not an issue.
Harvey, it's always exciting to hear you. I'm interested in your experience and the experience of the unbiased New York consortium, and how many of your patients actually have limited stage 1A disease, especially since many patients are under so-called surveillance, and hopefully we do detect them early, although I want to see your answer.
Well,
and of those,
I'll come back to that one first.
and of those, how many of them do not have a recurrence and may be considered cures?
So, with my series of about 300 patients, the number of pure stage 1s is approximately 10%. Okay? But you have stage 2s that are stage 2s because they got disease on both sides as well as they got a little bit of diaphragm stuff around the pericardium. Still can have lung sparing. So my role has always been do a lung sparing if possible. So it's only about 30% that are the real early, 10% that are the real early ones. Number one. Number two, when you do a pleurectomy decortication in those patients that are stage 1, 2, and you can do a pleurectomy decortication, the median survivals come way out. They come, but everybody in my series got chemotherapy. I was an early user of platinum-based therapy back in the 80s. So my series is a little bit different from that. Now, my feeling about surveillance and finding them early. There is no surveillance. There is no surveillance for this disease in the United States. You show me all good intentions. There is no screening program that has found mesotheliomas and has been able to take that into a therapeutic effect, period. Now, are we moving toward doing that? Absolutely. The Insulators Union are now involved heavily to be able to do multi-center trials, to be able to look at patients prospectively that are at high risk. The problem, though, is the following. For the person who's not an insulator that may have had some exposure, how do you quantitate how much asbestos he got? Do we have a marker that says, in your blood it says you had asbestos exposure? Actually, there is one that's being looked at now. So the bottom line is that you will find more patients if you do longitudinal screening, and that's where we are now. But you couldn't do that unless you had a means to do that. CTs fails at that all the time. How often can you do CTs? Every week? I mean, every month? You're not going to do that. You need to have either a blood test or a breath test or something that's going to alert you to the fact that something's brewing. And I don't care whether it's something brewing as a pleural effusion, but it tells you that there's something happening that in a series of studies before this, that marker says you better do something. And that do something is get a CT scan. How many patients live 15 years? Well, from 1989 to, I guess, 2013, yeah, I've got the follow-up. Precious few, less than 5%, less than 2%. But you can't use that number now. That number was based over a 20-year period where I was feeling my oats on what to do. New drugs came around, and we have new therapies now with more people doing resections for this disease. So I think that over the next 20 years, I think there will be longer-term survivors. My feeling also is that once you're able to find who's going to respond to certain therapies, you're going to select patients better. Now, the act of selection itself will make your survival curves do better. But if you don't select, then you're putting patients through things that they shouldn't be put through. So you're going to need to select, and that's coming with either molecular or proteomic types of markers. So that's 3 questions.
I think Harvey will be here for the coffee break, and so if you guys have other questions, maybe you could ask him at that time.